if when we are in gait, a lack of dorsiflexion or extension, however you want to describe it, of the hallux becomes very problematic. Okay, because what will tend to happen is we can't get ourselves into a good position to drop that first metatarsal onto the ground, right, and create a nice rigid lever here on the medial foot, right? So watch this. If I hold this in place here and I try and move that metatarsal, look how stiff that gets. Right, now if I release that, see how mobile that is? So even with me just holding it in place, it stiffens that up pretty badly, right? So you can imagine how that works when we can't get extension of that hallux because of an arthrosis, right? Which is probably the most common issue to have here. So functionally, we need at least 60 degrees here to have a normal stride pattern. Otherwise, what will end up happening is we'll end up rolling off the medial edge of the foot, externally rotating the foot, or abducting the foot, and all of our pressure and friction comes right over here. We end up with a reactive periostitis, which of course will irritate the joint pretty well. We'll end up building up a bunion, right? It starts peeling the periosteum away from the bone, starts thickening the bone. As that happens, we start getting separation of the first and second metatarsal heads. We get valgus of the hallux itself, the MTP joint, and then we will dislocate those sesamoid bones. Now all of a sudden, normal loading of the foot has effectively become impossible. Okay? So it always baffles me when we see surgeons go in to do resections here, and they'll straighten this, and then they'll fuse the first metatarsal joint, MTP joint. So now this thing is rigid, and essentially they're just dooming this poor person to the exact same problem happening all over again. So when we look at this, there's two little tips, because this is our treatment for the joint. Compression, compress the joint, and then produce a dorsal glide. Okay, now if you need to, you can produce the dorsal glide of the proximal phalanx, get to the barrier, and then you can actually produce a plantar glide of the metatarsal head. Relatively, it's the same thing. Okay? A lot of work on that when you have an arthrotic joint here. A lot of work, a lot of time spent doing that mobilization alone to stretch out that joint capsule.
Why compression?
For habituation purposes. Right, we talked about the habituation component. You need compression in the closed pack position to get good kind of saturation of the articular cartilage with the synovial fluid, right? And that's how it remains healthy. The compression there will help with that. Because in theory, you'd want to use traction to help stretch the joint capsule, right? But you're not going to get as much movement out of it, for one, and it's not going to help keep the joint as healthy. So always use compression when you're doing that. Now, the next phase here, if we can still palpate them, if they're still patent, is to go mobilize the sesamoids, because these things will get swollen and they will scar down. So that means coming onto the the plantar surface of the foot, getting onto the sesamoid and doing basically anterior and posterior glides, right? Trying to break up any adhesions. Do that for the medial, and then over here for the lateral. Okay, so sesamoid mobs is stage 2. Stage 3 is a flexion, isometric of the hallux. We'll block them off here. I'm going to keep it in neutral, straight across. And I'm going to say push your toe down into my thumb. What that should produce is a bowstringing of those sesamoids away from the articular condyle. Again, to break up any deeper adhesions that have formed. Okay, and then after that, step 4, I return here to do more mobilization into that dorsal glide. Okay, so step one, loosen the joint capsule. Do a good 5 minutes at least, maybe more, of dorsal glide here. Come down and do a minute or so of mobilization of the sesamoids. Do 3 or 4 isometrics, go ahead and push down there, Jerry, of the hallux flexors to bowstring those sesamoids away from the condyles, and then return here to work on improving this even more. Okay, that's my sequence. That's what I like to do here for that. And then I'm usually going to teach this patient how to do self-mobilization at home. I can teach them all 3 of those things if I feel confident that they'll be able to do it. But a lot of times all I'll do is teach them how to do the dorsal glide.
Any ideas for people who can't reach down to their feet, like those self-mobilization?
I don't know if I've ever had anybody that can't do that.
Yeah, a lot of
Well, what you could do is you could put something on the floor, right? So let's think about what maybe would work. Looking for common household items here. Basically, you probably need something, depending on how much range of motion they would have, you'd need something between a ½ inch and maybe 2.5 inches to prop up that proximal phalanx, and then all they'd have to do is just push their leg down over the top of it to produce that dorsal vector. I guess like you could think of maybe using like a dry erase marker. I personally probably wouldn't use something that's curved like that, but something that's about that thick. That would probably work. You're probably going to lack the compression that you would typically want to have, but at least it's something. Any questions about that?